So we move to the next session, and the next session is being led by none other than one of my very, very close friend, Alan Yan, who is going to moderate with the topic as cultural perception of pain. Over to you, Alan. All
All right.
yours.
Thanks, Rajiv. Haven't seen you for a while. Thanks for the introduction. And this is a great segue. And we are right on time. We're going to just start right away. And thanks for my panel members from all over the globe. So we're going to talk about the really important and interesting concept of the pain control in foot and ankle surgery. And it is really, as I said, it's really a great to have a segue to transition into this from the last topic. So let me start with my presentation first. Let me try. I had a little bit of problems with sharing my screen window, entire screen. Let me see. Oh, that's over there. Okay, let's see here. I think we have it. Sure. Screen two, share. You're sharing your screen.
We are able to see your screen.
Do you see it right now? Let me see here. Is it there?
Yes, absolutely.
Okay, perfect. All right. Okay, then let's go over. Okay, so let me just start. Foot and ankle surgery and also overall orthopedic surgery is really painful, as described in a lot of literatures, and also we experience it from our clinical experiences. And I had my panel of all surgeons from the corner of the world to share their perspective on the perception of the pain and management of the pain. And thanks a lot for everybody. You are all in different time zone, and we come over to this great opportunity to share our some insights in this really important topic. So let's talk about the tradition, trends, and alternative in the U.S. first, and then we look into the different cultures, if there are any differences, and why there are such an issue in recent years. So this is my disclosure, and so we started like this. And there is a phrase that usually in the U.S., when you go into medical school and you were taught that education was also 50% of what we teach you over the next 5 years or next 10 years will be inaccurate, or sadly we do not know which 50%. And that story is accurately described for the pain control. So if you go into med school in the 1990s, mid 1990s, or the early 2000s, so you were taught the pain is the fifth vital sign. So let's talk about some of the history of where does that coming from. So I looked it up, and it is from 1996, from the APS annual meeting. It was advocated by the then president of APS. We should treat the pain as a fifth vital sign. And that concept has taken up by the industry quickly, and also it's quickly absorbed not only the physicians, but also all level of providers. And so the compact of this one is considered to be one of the reasons and why we have today the epidemic of narcotics in the United States. So it's kind of like a perfect storm. And since that addressing American Pain Society, so I think the original intention is to taking care of our patient. If they have any kind of discomfort, we need to take care of, and not ignoring it. Well, it's a very complex issue, and once you're addressed one aspect, you probably you do not look at over other impact that may form, just as in this situation here. And also, you look at a history, the OxyContin, which is the long-acting narcotics, was introduced by Purdue Pharma around the same time. And the bestseller, blocking pain, but not targeting the sources, as it's referred later on when we looking back into history. And the diversion of black market of all varieties has been shown. And because of the quantity of the medications we give to the patient, and there are, this perfect storm has been brewing, and later on is getting into such a issue that we are facing nowadays. So I was wondering, is that only the American problem? So you look at those numbers, the United States is just making up about less than 5% of the world's population. And however, the patients consumes over 80% of the world's opiates. And let's take a look at other cultures today, so we can verify, whether that information is really that the other surgeons in other cultures has been experienced. And the U.S. consume, and also besides the oxycodones, U.S. consume approximately 99% of the world's hydrocodone. So the record of death rate, you look at the data from CDC, from the DEA, and those numbers, I do not have to repeat those numbers. And that is a bad situation from year to year since the 2000 on, and it's still going on today. And it's a complex interplay of physicians, the concept of the understanding of the pain and how we control it, and also the industry's responses and the policies goes along with it, and things goes wrong with all interplays. So the overdose and death, so many ascribe to the greedy pain hustlers and healers turning into a killer. And you're looking at the news and looking at all those graphs, it's all over. So if you look at the news and look at those informations. So I guess so all around the world, we most of us all have the access of Netflix, and those two movies is actually worse to watch. And in the media, so the physicians has been described as a chains of physicians, and the industry has been described as chains of culprits. And the depictions in those two documentary, and one is two movies, is actually it's really worth watching to understand it. So you're looking at like one of the documentary, as I mentioned before. So it was cooperated by one of the industry representative, and he's getting probation because of cooperation with the media and the industry, the pharmacy company who's come up with a long-term form of painkillers, and he's got like 1 year or something. But the physicians and one of the physicians that I know personally, and they got a sentence for 20 years. So it's still ongoing lawsuits, and what do we understand that today? So it's almost looks like a movement of reversing what we were doing in the past. So what do we usually do in the past as experiences of a surgeon? And a number of us are pain specialists, but in the perspective of a surgeon, what do we usually do? In the U.S., as I experienced with my training as a medical student resident, and I started my practice, the outpatient routine, we usually would give about oxycodone 50 to 80 tablets for outpatient procedures, very commonly seen. And also you very commonly you added OxyContin for about 30 tablets, or extended for a couple of weeks. So also the inpatient routes and PCA, patient control the anesthesia on top of a nerve catheter and blocks, and upgrades in the PRN, IV narcotics is also very common. So with all those things happening right now, the current epidemics, we have a wake-up call, and all physicians are nowadays required to have continuing educations and pain management, orthopedic surgery when you recertify and also DEA requires education each year, and many other adoptions has been used in the United States to try to curb this situation. So mandatory annual CME and the CDC updated their guidelines, and the most recent one that I looked up from 2022, and also that was a consummate input from the general public, patients, advocates, surgeons, anesthesia, pain management, and pharmacists. So the key is that we know is right now is we need to try multimodal pain control, which is the key, and CDC 12 updates recommendations, and this is the timeline for their prescribing opiates. And essential, the 2022, the guideline is we should prescribe opiates at the lowest effective dose for expected duration. And the guideline also endorsed patient-centered approach to the initiation and the tapering of opiates quickly as they possibly can. So I'm not getting into all those details due to the timing. So also exhaustion of non-narcotics alternative is often mentioned in all guidelines put up formally by the government like CDC or DEA. So pharmaceutical alternative is also non-pharmaceutical alternative like physical, cognitive, has been mentioned. So the key takeaways for the current management recommendations for surgeons and physicians is we choose immediate release agents over the long-term ones. So lowest effective dose and quantity, gradually tapering, monitor evaluation and re-evaluation on regular basis, and the education, risk and harms and mitigation from the specialist. And there is a system we call the PDMP in the United States. So instead of prescribing from a paper that was many years ago, and now it's all online, and also before you confirm you're going to prescribe those medications, you need to go through a couple of steps to make sure the patient's not getting their narcotics resources from other resources besides you. Polypharmacy watches also, you can use a toxicology test to make sure the patient is not taking other pain medications besides the one they required from the surgery, and cautions with simultaneous use of the CNS depressant and detoxification measures offering to the patients also. So here is the question then we're asking: are we like so special, or patients population really special? You look at the international prescribing habits of physicians looking into those literatures. There are a study from the Netherlands, the level 1 trauma center versus US level 1. So hip fracture, 77 American needed narcotics versus 0 for the Dutch patient. And an ankle fracture, which is that we do all the time, and 82% of American needed narcotics versus 6% in the Dutch patient. So then we're asking this question, we're looking into, is that cultural? Is that pain perception and management? Is it just, is it genetic or cultural, or something that we do not know? So as I grew up as an Asian, was with a family, my parents and my grandparents is what we look at it. There's a famous saying, it is no pain, no gain. So the cultural perception usually from Asian Pacific populations, and they take pain as like quite a normal reactions after certain stimulations, and they even welcome it. And later, if we have time to mention, one of the biggest alternative that we use it today, acupuncture. That's quite an interesting topic looking into the history. And the Asian patients, you look at their acupuncture responses, if they do not feel any kind of pain, distension, they don't feel it's going to work. While in an American patient, if you have any pain, you just insert the needles, they may not see you again. So that's something interesting that we look at it. So for the ankle surgery is really painful, and so my current strategy is also anticipation management of the patient. I usually tell the patient, I learned from one of the attendants during my residency, So the first week you feel like you're hit by a truck, then you hit by a car the second week, and the third week you feel like you're hit by a bicycle. So it's anticipation of a gradual reduce. And we use regional nerve blocks and local wound infiltrations, and try to use multimodal analgesics using Tylenol, NSAIDs, and Resco short release narcotics only when it's not moving, not working. So the multimodal has its a history. We refer to Dr. Khaled, and he has a lot of work has been done on the multimodal versus monomodal type of pain control. And the pre-op, peri-op, post-op team approach is something we need to look at. And those are the detailed recommendations, and we can also it's all over the recommendations, the formal recommendations from the continuing education and government recommendations. So we still call for actions, but compared to probably years ago, it's a lot better. And so the non-pharmacy options, and later, if we have some time, we can mention about that. And now it's the time that we look at the other location of the world and how we deal with this, how we look at this. So the next speaker in my panel, I think, is Satoshi, Dr. Satoshi Yan. Yeah, thanks.
Can you hear me?
Satoshi. All right.
Hi. So, can I start my presentation? Is it okay?
Yes, please.
Okay. I'm going to share my slide. Can you see my slides?
Yes.
Great. So let's start. First of all, I'm honored to have a presentation at this wonderful meeting. I'm Satoshi Yamaguchi from Chiba University. My talk is about pain perception and management, Japanese perspective. Today's presentation will cover the following topics: perception of pain in Japanese healthcare system, routine pain management, and minimal invasive surgery. So almost 100% of my patients are Japanese. I have no experience treating those with other cultural and regional backgrounds. However, I believe that Japanese patients have unique characteristics regarding pain perception. In Japanese culture, enduring pain is often considered as a virtue. Many patients accept a certain level of pain. There's also a reluctance to express pain openly. So in summary, Japanese patients may be considered very, very stoic. Japanese patients tend to use fewer analgesics, especially opioid, because of concerns about side effects and addiction. One study showed that among older adults, only 12% of older adults use pain medications, and less than 1% use opioids. So I recall patients saying, I don't want to have surgery in the left side because I can't stand post-op pain, even though the post-operative cost of the right foot was very good. This highlights the importance of post-operative pain management, even in Japanese patients. Oh, sorry. So recently, Japanese surgeons are increasingly recognize the need for active management of post-operative pain. So let's move to the next session, the healthcare system in Japan. There's a lack of anesthesiologists in Japan. In a hospital, specifically, lumbar and epidural anesthesia must be performed by orthopedic surgeons. It's unbelievable, but it's reality. This consists of more than 60% of surgical cases. Anesthesiologists handle only general anesthesia, which are less than 35% of cases. Also, physician-performed ultrasonography is very common among Japanese orthopedic surgeons. It is used for both diagnostics and treatment, such as intra-articular injection. Therefore, we perform nerve blocks by ourselves. Another aspect is Japan allows for very long hospital stays. For example, ankle fusion, 14 days, total ankle 14 days, hallux valgus as many as 20 days. This provides sufficient time for pain management. There's a clear difference between Japan and the US regarding opioid prescriptions. According to a recent questionnaire survey, in the United States, 70% of orthopedic surgeons prescribe opioid medications to control post-operative pain in more than 80% of patients. In Japan, 27% of surgeons prescribe opioid to less than 20% of patients. The type of opioid used also differ. In the United States, hydrocodone analogs are used only in more than half of surgeons. In Japan, tramadol analogs are used in 76% of surgeons. So the use of oral strong opioids after orthopedic surgery is extremely rare in Japan. So now we'll discuss our routine pain management. So for major surgeries such as total ankle replacement, ankle fusion, and complex forefoot procedures, we use single-shot popliteal blocks, sometimes combined with surgical site infiltration. For minor surgeries such as simple forefoot procedures, surgical site infiltration alone is used. Previously, we used epidural anesthesia. However, we shifted to nerve blocks because they have fewer side effects, such as hypertension, and allow for earlier ambulation. Potential complications include motor weakness, which is not a big problem because a longer hospital stay is allowed in Japan. Systemic toxicity is minimized by using diluted solutions or combining with surgical site infiltration. However, a long procedure time is a problem. A routine medication protocol includes celecoxib as standard, acetaminophen, and diclofenac as rescue medication. Pregabalin is not routinely used. And again, we never use opioids. We sometimes IV PCA, but in selected case with general anesthesia. You may think that we use traditional medicine such as acupuncture and herbal medicine. Herbal medicine is very commonly prescribed in chronic pain and medically unexplained symptoms in the outpatient settings. Actually, our hospital has a department of Oriental medicine, but I have no experience using it for post-operative management. Acupuncture may be effective, but again, I have no experience using it for post-operative management. So finally, we discuss less invasive surgery. There's a trend toward less invasive surgical techniques in Japan, as is the case in the United States and Europe. For example, in hallux valgus surgery, we now use distal MIS surgery instead of mid-shaft osteotomy, which I used to perform 3 years ago. Also, we perform all arthroscopic percutaneous ankle fracture fixation in selected cases. However, in some cases, such as lateral crouch total ankle, a large incision is still required for adequate treatment. Therefore, intensive pain management is needed for early recovery of the patients. So in summary, Japanese patients are reluctant to express postoperative pain. This highlights the need for surgeons to be actively engaged in pain management. Opioid use is very limited due to patient and surgeon concerns, as well as healthcare regulations. Nerve blocks, surgical site infiltration, and multiple medications are the mainstay of multimodal management. Thank you for your attention.
All right. Thanks a lot, Satoshi.